Hello, everyone, and welcome to the next home study course offering by Premier Sports Services. My name is Brian Kosan. I am the coordinator of continuing education here at Premier Sports Services, and I will be doing the presentation on brain MRIs and concussions. Giving you a little background about myself, I've been working in athletic training since 2008. I have experience in clinic-based outreach, junior hockey, and for the last several years I have been working in a physician's office, and that physician is a concussion specialist. So we get to see this kind of stuff fairly routinely and want to be able to share that background with all of you. A few little disclosures we're going to need to take care of per BOC requirements. And those are namely the fact that I do not have any conflicts of interest to disclose, as well as there's quite a few videos and pictures that are utilized throughout this presentation, and all those rights belong to the respective owners. I don't really own any of the images or videos that are coming through. One additional thing that we do need to talk about, and that is on slide 17, I'm going to be including a video that was produced by a company that offers MRI testing and analysis to lawyers. And I have to say that I, nor Premier Sports Services or the Board of Certification in any way recommend or endorse this company. It's just purely presenting their material, and I've tried to edit at that video to bring out the educational material in it, but not anyway promote their product. So now with that kind of done and out of the way, I kind of want to move into our learning objectives, because we have quite a bit to cover in the next hour that we're going to be kind of at this. Okay, so one of the first things that we want to try and do is touch on the indications for advanced imaging in concussions and head injuries. We want to define the strength of an MRI magnet and its overall impact on the image resolution that we get. This presentation, as we talk about a lot of the stuff with MRI, it's not just specific to brain MRIs, but MRIs as a general whole, which hopefully will be quite useful to our audience. I would like you to be able to recognize various MRI sequences and identify their roles, of what they kind of tell us. What are they good for? More specifically, I want you to be able to define diffusion tensor imaging, or DTI, and its role in neuroimaging. Identify normal findings in neuroimaging as well as abnormal findings. So you can kind of look at that and see, okay, what looks normal, what doesn't, and once again, make heads or tails of these things. And kind of lastly, as a kind of an overall goal, an objective that I have for this learning event, is that I want you to kind of walk away with an understanding of how referral and intervention considerations are kind of how we come to those from these images that we generate through these advanced processes. Now that we've kind of cleared through our learning objectives, kind of starting out very simple. What are our options that we have for advanced imaging, and when would we consider using each? So kind of starting from the top, we have our classic CT, or computed tomography. These are derived from X-rays, and they are pretty much still our go-to move when it comes to the acute setting, because they have a very high sensitivity to things like fractures, because obviously they're X-ray based, as well as finding things like life-threatening bleeding, because we don't need to be able to see detail of structures, we just need to see abnormalities within a tissue. These are also CTs are still very much our go-to move because they're fast. You can put somebody in a scanner and have a pretty good idea of what's going inside their head and neck within just a couple of minutes. So some of our indications even further that we would think someone needs a head CT, at least for us as athletic trainers, would be acute levels, changes of level of consciousness, stigmata of skull fracture, so our classic things like battle sign, raccoon eyes, drainage of cerebral spinal fluid from the nose or ears, elongation of the face, depressions or other suggestions of skull fracture. So these kind of those overall physical representations or physical findings of skull fractures, as well as things like Cushing's triad, which is a representation of physiologic change from increased intracranial pressure. And so these would be things like a spiking blood pressure and a dropping heart rate and respiratory rate. These would all be suggestions that we really need a CT for our patients so that we can better guide our care. Then, of course, there's our MRI. That's going to be the highlight of our presentation today. This imaging is derived from electromagnetic fields that influence the hydrogen ions and atoms of our body, because they're essentially little magnets, and we have a lot of it. We're 70% water, and by manipulating these atoms, we can get different energy signatures, which create pictures that we can use to see soft tissue, and that's why MRIs are the ideal medium for looking at soft tissues because of the high water contents. There's a subset of advanced imaging when it comes to MRI, and that's the functional MRI. The functional MRI is a very specific application where we're looking at essentially marrying the idea of an EEG or an electroencephalogram, which looks at the electrical activity of the brain. But we kind of like superimpose that over an MRI, and we can kind of really look at the function, what parts of the brain are functioning during particular tasks. The last advanced option we have in head injuries is a PET scan or a PET, and these types of scans use radioisotopes that have been put into the patient's body, usually through IV, and these isotopes tend to settle in various tissues, particularly ones with really high metabolisms, and therefore we can have a better determination of what a cell's doing, what regions of the brain are doing certain things, and these are really great for finding things like malignancies and tumors. So really today the primary focus is going to be on MRI, but I have a few quick little videos here coming up where we will kind of look at each one of these very briefly so we have an appreciation for them. Alright, so let's go ahead and get started and watch the first video going into the principles of CT scans.
A CT scan is an X-ray procedure that creates cross-sectional images with the help of computer processing. CT images are more detailed than conventional X-ray images and can reveal bones as well as soft tissue and organs. A conventional X-ray uses a fixed tube that sends X-rays in only one direction, while a CT scanner uses a motorized X-ray source that shoots narrow beams of X-rays as it rotates around the patient. There are special digital X-ray detectors located directly opposite the X-ray source. As the X-ray passes through the patient, they are picked up by the detectors and transmitted to a computer. Image slices can either be displayed individually in two-dimensional form or stacked together to generate a three-dimensional image that can reveal abnormal structures or help the physician plan and monitor treatments.
Moving on, this next video is going to provide a kind of foundation for how an MRI works based on its physics, and it's going to be something that's going to tie it back to throughout the presentation.
MRIs use protons, which are abundant in the human body. All protons spin, creating a small magnetic charge. When a strong magnetic field is introduced, as is the case in an MRI machine, the protons align with that field. The MRI technician then introduces a radio frequency pulse that disrupts the proton and forces it either into a 90-degree or 180-degree realignment with the static magnetic field. Since the radio frequency pulse pushed the proton against its nature, once this pulse is turned off, the protons realign with that magnetic field, releasing electromagnetic energy along the way. The MRI is able to detect this energy and is able to differentiate various tissues based on how quickly they release energy after the pulse is turned off.
Moving into our next video, this is going to be pretty much the only chunk that we'll have on functional MRI. It's about a 6-minute video, but it gives a pretty good overview of what we're looking at.
The brain is a marvelous thing. The most powerful computers on the face of this earth, the ones that fill up whole warehouses, cannot keep up with the awesome power of your 1.5 kilograms of squishy material sitting inside your skull. But how the brain does all of these amazing things like create thoughts, emotions, intelligence, or even consciousness was for a long period of time uncharted territory because scientists didn't have the methods to look inside a brain in action. Now, if we could look inside, the benefits would be tremendous. Not only could we create computers that are much, much better or develop new treatments for mental diseases, but we could start answering very fundamental questions about who we are and what makes us human. Now, scientists had to wait until 1992 for a new method to be invented that would allow them to look inside a brain while it performs a certain task. That method is called functional magnetic resonance imaging, or fMRI for short, and it has allowed us to learn about what every single brain area does. Now let me try to explain to you how this very important method works. Step inside an fMRI machine, an incredible feat of engineering. The largest part of the scanner is a very powerful magnet that creates a magnetic field 10,000 times stronger than the Earth's magnetic field. Today we're going to take a look at how this incredible machine actually works and how it has enabled us to see which brain areas are more active. Now, what does it mean when a brain area is more active? Well, the brain is made up of neurons, and these communicate with each other using electric signals. Now, a brain area is more active when the neurons inside that brain area start sending more signals than before. For example, if I start moving my arm and I see a brain area that lights up or becomes more active, then I know that that brain area probably is responsible for my arm movement. Now, it is possible to measure electric signals directly from the scalp, but the problem is finding the exact origin of that signal because all brain areas are sending signals all the time and overlaying with the signal that you actually want to measure. Now, fMRI can solve that problem, but it involves 3 things. Neurons have a pretty nifty trick up their sleeve. When they become more active, they need more oxygen, which they get from red blood cells. So what they do is they actually widen the blood vessels surrounding them in order to attract more oxygenated blood. Now that means when a neuron becomes more active, the oxygen concentration in the blood increases there as well. Our bodies are mainly made up of water, and each water molecule has something called a spin, which gives it its magnetic property. Now, you know how a compass always points to the north because it wants to realign with the Earth's magnetic field? Well, you can do the same thing with water molecules, but you need a much, much stronger magnet, like the one from an fMRI machine, to achieve something like that. Now, suppose you have them aligned in your strong magnetic field, like that, and you add a little bit of energy in form of radio waves, you can actually force them into yet another alignment, something like this. Now, if you stop sending radio waves, they will start to be attracted to the strong magnetic field and wobble back to it. Now, as they do that, they send radio waves back to you. Now, in the beginning, you can see that they're very much aligned to each other and that they send radio waves at the same time. So that means the radio waves can add up to give you a very strong signal. But with time, they start to desynchronize and send radio waves at different points in time, which means the radio waves cannot add up and the signal that you measure weakens. That's like a team of tug-of-war pulling on a rope. They all have to pull at the same time so that their forces add up. Now, with time, as the water molecules desynchronize, your signal becomes weaker and weaker and weaker. And with that, we're now ready for the final piece of the puzzle. Magnetic fields, like this one here, can have small disturbances in them that cause water molecules to desynchronize faster. Think of two coins spinning on your desk and one of them constantly bumping into other objects. Well, that one will stop spinning earlier, right? Well, the same goes for water molecules. Turns out that deoxygenated blood causes such disturbances, while oxygenated blood doesn't. So now we can put everything together. A brain area becomes more active, causes the blood vessels to widen, meaning more oxygenated blood flowing towards it. That means less magnetic field disturbances, the spins synchronizing for a longer period of time, and the signal that we want to measure staying for a longer period of time. So in other words, what fMRI is doing, it looks at a particular brain area and repeatedly measures how long the signal stays. And when that signal starts staying longer, we know there's more oxygen, and we know that that brain area is becoming more active.
All right, so one of the last advanced imaging methods that we would like to kind of look at really quick is the PET scan.
A PET scan creates 3D images of the body. It does this by using radioactive tracers, which are usually administered to a patient through intravenous injection. The tracers are made up of carrier molecules that are tightly bonded to a radioactive atom called an isotope. The carrier molecule can interact with or bind to specific proteins or sugars in the body. The carrier molecule that will be used depends on what the doctor is looking for. If she suspects cancer or is monitoring a known cancer's growth, she may use FDG, a modified form of glucose, which gets absorbed by tissues. When tissues absorb a lot of glucose, it may indicate a cancerous tumor. The radiation from the tracers poses little danger to the patient since they quickly pass out of the body. The isotope produces small particles called positrons, which interact with surrounding electrons. This interaction results in the complete annihilation of both particles, releasing two photons that speed off in opposite directions. The detectors in the PET scanner measure these photons and use this information to create an image of the distribution of FDG in the body.
Okay, so now that we've covered those videos and covered the basic physics of each of these and really lay that foundation for MRIs, we're really just going to focus on MRIs for the remainder of this presentation. So in the video, we talked about how the MRI magnet and its strength makes the protons of the body spin in a line with that powerful magnetic field. If we kind of imagine the idea of that stronger magnet pulling that proton further over, essentially with more force, we think about like a catapult. If we take this, like a big catapult, it's going to have more energy versus a little smaller one, right? And so the idea is that if we have this more powerful magnet, we put more force into that to that proton, and it's going to snap back harder when we introduce that radio frequency field, and that creates better resolution because we have essentially more energy to take a picture of. So MRIs are measured in a unit called Teslas, and to give you context of this, the Earth's magnetic field is only 50 microtesla, so very, very tiny. Not very strong at all compared to the strengths of these particular machines. So fundamentally, we have three levels of MRI strengths that we will see that are practical for routine use on patients. So starting at the bottom, we have our 0.3 to 1 Tesla strength MRIs. And these are the typical strengths that we see in our open MRIs. And we see this somewhat drop in comparison to other MRIs because we are giving the patient more freedom. There's more space. There's not this solid bore that's around them. So without having these big magnets or these smaller magnets, we can't produce as big of a field. But then the patient doesn't feel claustrophobic. There's a little less noise. And once again, the kind of sacrifices that sometimes are being willing to be made. And then we have the 1.5 Tesla. This is kind of like our standard MRI that most people get. And they're simple, they're more cost effective for the most part, and give decent resolution. And then there's our 3T MRI, and this is the strongest clinically practical, and I got to stress that it's clinically practical MRI, and we'll talk about that here in a moment as to the case of why that is. And these give very high resolution results and very fine tissue detail. Some would even call it like high definition, or like 4K if you're thinking about high-end TVs. So those are 3 clinically practical levels, but there is a 4th level, and that is a 7 Tesla MRI. There's only a handful of these that exist. They're so powerful, they need to be kept in a bunker because they will pull things like cars in the parking lot towards them. So it's a protection thing. And they generate so much heat, both in the machine and in the tissue that they are testing, that a human being can only tolerate being around it for a couple of minutes. Estimates vary between like 15 and 20 minutes. But I mean, the detail these things are able to create are down to the micron level. So I mean, pretty significant. And I actually have some images I can show you here in just a moment. But kind of just giving you an idea of what we're looking at when we're seeing these strengths and what kind of resolutions we get. I was trying to find images of open MRIs of the brain, and they're just really hard to come by because they don't really give the resolution that a lot of people for neuroimaging are really looking for. So we're going to start out with one at the hip, because it's one I can find, and I can actually find the field strength. So this came in at 0.34 Teslas. We still can see pretty good detail. We can make an outline out of things like our femoral head and the femoral neck. So we can still see that kind of quite nicely, but on a neuroimaging level, it's not really quite enough. To kind of give you a comparison, I have both a 3T and a 1.5 T image of the brain. 3T is on the left and 1.5 is on the right, and it's of the same brain, same slice, and you can see that there's just a bit more detail, and not by a bit, I mean certainly a bit more, on that image there in the 3T. So certainly very beneficial, and as we get into a little more advanced stuff, it kind of gives you a little more bang for your buck. But they're expensive, and now, once again, there's more 1.5 Tesla MRIs out there than there are 3.5 Teslas. As I mentioned before, there is 7 Tesla MRIs that exist. And recently, there have been some published images from some studies done with a 7T. This is an image of a patient that was deceased, because once again, a living person really can't be around an MRI of this strength for more than about 15-20 minutes. So this patient was deceased, and this scan took 100 hours, and thankfully was able to remain completely still. But the detail that you're able to get down to, the fine structures that you would kind of see through here, like the parts of the various fibers within the ventricles, very clear distinctions in the gray matter versus the white matter, into the various structures of the cerebellum. So this very fine detail. And these images particularly are out of Boston. Very beautiful stuff, and I'm going to follow this up here with a quick video of actually the slices. They kind of animated some slices of an MRI sequence from the 7T scan of the brain. Pretty amazing stuff. Really amazing detail. It gets down to quite literally a dissection level of detail that gives just a huge treasure trove for analysis. So now that we're going to start looking at some MRIs, how can we tell what we're looking at? How can we make heads or tails of what we're doing? So various tissues have different rates of relaxation for at what speed and what ability that proton has to return back to its desired position in the magnetic field. And then, based on these relaxation rates, we get different levels of contrast within the tissue. We label these rates of relaxation with numbers and symbols, and these are typically referred to as T1 and T2. And each tissue has different characteristics within these relaxation periods, and this once again allows us to identify the type of tissue that we're looking at as we're looking at these scans. We can even further kind of manipulate these relaxations to essentially weight them, so that way we can emphasize a certain tissue or suppress a tissue as we're looking at a particular type of thing. So do we want to see more water? Do we want to see more fat? Do we want to be able to suppress fat so we can better see different tissues around it to be like more protein based, for example? And once again, that all depends on what we're trying to accomplish in that scan. So, as I kind of said, every time we look at an MRI image, we need to get our bearings. And the best way to do that is to find something with a high water content. And specifically in the brain, we're looking at things like the cerebrospinal fluid or the ventricles of the brain. These are going to have a lot of water in them. And we need to ask ourselves, are they whiter or are they darker? Okay, are they blackish? And so in the world of MRI, if it's more white, that's referred to as bright. And if it's more black, it's referred to as dark. Okay, and so in a T1 weighted image or sequence, water will be dark. And in a T2 image, water will be bright. One of the authors of the sources that we used would be David Kowal, really suggested that we look at this as a mnemonic, and one way to remember that effectively is that the number 2 appears in both H2O and T2 weighted image. So you can always kind of keep that in your mind of, okay, if water is bright, then it is a T2 weighted image. All right, I want to get in now to the classic MRI sequences that we'll see with the brain series that we'll go for. And this is done by a medical student that did this a few years ago, that gave a kind of quick little brass tack way of really recognizing and appreciating these sequences and kind of make it really boilerplate. And I think it'll be very useful for us.
Okay, so let's start with T1 versus T2. Very similar sequences, and people get tripped up a lot with these. So between T1 versus T2, we've got 2 basic rules that differentiate the two. Number 1, within a given sequence, so take T1 for example, water and fat are opposite signal intensities. Number 2, between sequences, T1 versus T2, a given substance, take fat for example, will have opposite signal intensities. This will make sense in a minute. And let's start with T1. Here's our T1 image. How do we recognize T1? Well, in T1, fat is bright, water is dark, and new blood is bright. And this is useful for anatomic details. We can pick up vascular changes and disruption of the blood-brain barrier when we add in contrast. So let's take a look over here at the image. So water, or CSF, is dark, and fat is bright. So areas where there's a lot of myelin, these deep white matter tracts, are going to show up bright, whereas outer cortex is not. This isn't the best image to demonstrate this, but you'll see the differences when we move on to T2. So let's pull up our T2 image. How do we recognize it? Well, everything is flipped. So now fat is dark. These highly myelinated areas here, which are fat, are dark. Water is bright. So look at our CSF right here in the ventricles. It's pretty bright. But flow is dark, and this is called flow void. So where there's fluid moving at a high velocity, so take a blood vessel for example, it's going to be dark, and that's important to remember. What is the sequence useful for? Again, anatomic details. I think T2 is probably a little bit better than T1, especially our CSF spaces here. It's useful at picking up most lesions kind of in general. One area where it can trip up a little bit is when you have lesions or edema really close to CSF spaces, because they'll both be bright. Okay, so let's compare these two. We've got T1 here and T2. So fat is bright on T1, fat is dark on T2. CSF is dark on T1, bright on T2. Got it? All right, let's move on to FLAIR, which stands for Fluid Attenuation Inversion Recovery. Sounds confusing, but that'll make sense in a minute. So here's our FLAIR image. I like to think of FLAIR as basically a T2 image, but the CSF spaces are flipped back to being dark or hypo-intense. So if we look here, it looks just like a T2 image. So for example, these deep basal ganglial structures here, which don't have as much fat in them, are looking pretty bright. Fat is dark, but the CSF is also dark. Interesting. Also, non-free-flowing water is bright. That'll make sense in a minute. Fat is dark, already went through that. So what is this useful for? Same as T2, but it does a better job of delineating lesions near the ventricles, because edema would be bright, but in FLAIR, the CSF is going to be dark because it's free-flowing, whereas edema is not going to be free-flowing. And it can really do a good job of gray-white differentiation. Just look at the putamen and the head of the caudate. They really stand out. And let's compare this to a T2 image. So again, it looks just like the T2 image, except that the ventricles or the CSF spaces are inverted. Okay, so here's an example of where FLAIR can do a better job of delineating lesions near the ventricles. So we've got our T2 image here. We've got something causing edema, and it comes right up against the ventricle here, and it's really tough to tell whether or not this is the ventricle, or is it completely obliterated due to the edema. It's really hard to tell. But if we compare to FLAIR, we can see nice delineation here between the area of edema and the actual ventricle. Moving on to GRE, or gradient echo. You'll also hear about this referred to as susceptibility weighted imaging, or T2 star. And technically these are different sequences, but for the purposes of our talk, we're just going to consider them all as one. So here's our GRE image, and how do we recognize it? Metals are dark, so things like blood, calcium, other types of metals are going to show up on GRE. And what do I mean by other metals? Well, there have been cases, for example, of Wilson's disease where we actually can pick up on the copper deposition in the brain. What is this useful for? Early hemorrhage. Not many sequences can pick up on early hemorrhage. This one can. Old hemorrhage. So old hemorrhage secondary to deposition of hemosiderin. So let's pull up another image here to compare. And just by looking at it and what we've been talking about, can you tell what sequence this is? So we've got myelin here, which is bright. That's fat. CSF is dark, so it's got to be T1. Okay, so let's compare. Here you can see we've got an area that looks sort of edematous, but we're not really sure why. But if we compare to GRE, we can see quite clearly that this is an early hemorrhage, and that's why this sequence is so important. Moving on to DWI, or a stroke service's favorite sequence. DWI stands for diffusion weighted imaging. More on that later and what ADC means. DWI is hugely important because it is the only sequence that can pick up on early ischemia due to an ischemic stroke. Another very important thing about DWI is it's a sequence that can be performed very, very quickly, whereas many other MRI sequences can be quite slow. So how do we recognize it? Fluid restriction is bright, which stands for cytotoxic edema. So right here we have some bright signal. And what do I mean when we're talking about fluid restriction and diffusion? Well, DWI is basically measuring the Brownian motion of water molecules, and it's helpful to think of only the water molecules in the extracellular space. So what happens when we have an area of ischemia, the cells in that affected area are going to start swelling. That's cytotoxic edema. And what happens because of the swelling, the extracellular space starts to shrink, and that gives our theoretical water molecules diffusing around in that space less space to move around. And so we would say they're restricted. So when we see an image like this, what we would say is we have an area here of hyperintensity, which is indicative of fluid restriction, secondary to cytotoxic edema, secondary to a likely ischemic stroke. Very important, you must correlate these findings with ADC. And ADC stands for apparent diffusion coefficient. And the way I like to think about DWI images is as if they were a stack of pancakes. It's multiple images layered on top of each other to give you one image. So one of the images is ADC, which I like to think of as just the raw data. And then there's also a T2 image pancaked on top of it to give you some anatomic detail. So what can happen is if you've got an area of very high intensity in T2, it can shine through the pancake stack and trick you into thinking you've got an area of ischemia, when if you went back and looked at just the raw data, you wouldn't see it. So on ADC, fluid restriction will be dark. And again, we're using this to rule out T2 shine through. So it's useful for ischemia, abscesses, and seizures. And let's compare to our ADC. So bright on DWI, dark on ADC.
Okay, so a lot of information that we've covered to this point, but let's kind of sum it all up here. MRIs provide better detail overall for soft tissue because of its sensitivity to the water content. As a general statement, the stronger the magnet, the better our image resolution. And let's go with this premise for all intents and purposes. T1 weighted, T2 weighted, FLAIR, GRE, and DWI sequences allow us to see and identify and appreciate different types of structural changes in the brain. And this is all fine and good. In fact, this is wonderful. Except we have one little problem. Concussions are a temporary functional change in the brain and not a structural injury. But don't worry, there's DTI. So what do we mean by DTI? We've got diffusion tensor imaging, which was a next generation or a step forward in diffusion weighted imaging. By its very nature, DTI gives us the ability to look at individual neural tracts and therefore even getting down into the true microstructure of the brain. And we can also even go deeper than that, and because of the diffusion information we get, we can use that movement of water as a metric for the overall function of that nerve and that neuron. We talk about this movement of water as a direction, okay, and as a direction and an amplitude, and we use a unit or a measurement that's called fractional anisotropy, or FA, and that's a very, very important part of what we're looking for in a DTI image. These FA has a value of pretty much between 0 and 1. And so 0 is, as you'll kind of see in a video here coming up, that it's like that drop of ink that's dropped into a beaker or a thing of water, and essentially those molecules go in every direction completely chaotically. To the other extreme, which would be a 1 in FA, and it is like a purely linear movement, which we don't see a ton of in nature, but we can still see certainly a high amount of it where we start to see not so much of that movement. We can see very, very linear progression of the water. What's really cool about DTI is that a lot of this data can be pulled together to create a 3D rendering of the individual neural tracks, and we call this tractography. And when we look at tractography, the applied color scheme is red, blue, and green, and so things that are moving essentially left to right or in the x-axis are going to be red. Things that are going superior to inferior in the brain are following essentially the y-axis will be blue, and anything that is moving kind of anterior, posterior direction, the z-axis will be green. We've done enough studies with DTI and functional MRI and done dissections that we can actually create a very detailed maps or atlases of the brain, and we can then better connect the imaging findings to other test findings, like say neuropsychological testing, which is pretty cool and very, very promising for our ongoing management and treatment of our concussion patients. Okay, so let's get into looking at DTI and kind of explaining and exploring that just a little bit further.
So why do we perform DTI? Well, DTI interrogates the white matter of the brain, in particular the microstructure, and that's the most important location of pathology. And DTI differentiates patients who have traumatic brain injury from those of normal controls, and this can be seen years after the injury. So let's talk about axonal injury. This is an axon, and there's actually billions of them in the brain. So let's take a cut through the brain and show you a pathway from one area to another. Well, there's millions of axons along this one pathway. And we will be looking at all of the different tracks of the brain that are important to us in terms of cognitive function, memory, and other abnormalities that occur after an injury. So remember, again, that we're looking at the axon, and what we're looking for is axonal injury. And here's how it works. This is an axon, and if you focus on the yellow area, it's basically the conducting portion of the axon itself, sort of like an electrical wire, if you will. And wires have insulation, and this area here also, this yellow area of the axon, is insulated with what they call myelin. It's a myelin sheath. So it's important to remember that these are cells of the body, and they have an insulation around them called myelin. So the procedure is as follows. Naturally, we put the patient in the MRI machine and we scan. And in the scan, we'll get routine MRI studies that produce these black and white pictures, the three on the left. But in addition, we're going to do DTI studies that produce tractography, which we don't use for interpretation, but that's what gives us our data that we will analyze. So again, we have three pictures on the left and the tractography on the right, which we then evaluate the data. So what will we be analyzing? Well, we'll be looking at that axon that I showed you earlier, and we'll be looking at the path of the water molecules as they move across the axon, which is insulated. And we'll scan 48 regions of the brain, which have been defined by Johns Hopkins University, in order to see all of the white matter tracks that are important to cognitive function. And we do this in order to determine whether there is nerve damage or axonal injury. What we do is evaluate what is scientifically called fractional anisotropy, or FA. So remember the term FA. So the main term that we are using is diffusion. That's the first word of diffusion tensor imaging. I'll explain it to you by showing you how a drop of ink into water diffuses. You can all see this right in front of you right now. That's diffusion. And it's random. So the diffusion that I just showed you in that flask of water is very much like this round cell where the diffusion is very random in all kinds of directions, actually an infinite number of directions. What we're looking at is the axon, which is on your right here, and it is linear and it's directional. So that myelin sheath that I told you about, the axon, keeps the water moving in a certain direction, or the water molecules. And that allows us something that we can measure with diffusion tensor imaging. Let me give you an example. In the last slide, I showed you how the axon basically allows the water molecules to move in a certain direction. But for a moment, think of a copper wire with insulation around it, and the multiple wires that are in a fuse box or any electrical connection. The copper wire moves electricity. Well, the axon moves water molecules in one direction, and the myelin sheath makes it go in that direction, divorced from all of the others around it. So it's protected in that direction. So you need to have insulation from the myelin, which can get damaged. So if you think of it as the electrical circuits of the brain, and you think of all the different connections going in different directions with different colors, you get some idea about what we're studying with diffusion tensor imaging. I know it's complicated, but this is the simplest way to think about it. So to reinforce what I told you about in the last slide, you have to think of the brain as a compact, complicated electrical junction box with wires going from front to back, right to left, up and down. And while wires require plastic and other materials as insulation, these tracks in the brain with water molecules require a myelin protection for each of the directions so that there's no short circuits. And we know what the short circuits do. They give you cognitive problems and memory problems and personality changes. That's the easiest way I know of to allow you to think about how the brain works. As we evaluate your client, who may have all types of signs and symptoms in a post-concussion syndrome, we'll be looking into the brain to see what it is that is abnormal, where the axonal injuries might be. In doing so, we'll be discussing two terms frequently. The first is fractional anisotropy, or FA. Remember that term, FA, because it may be high, it may be low. And the second is a Z-score. The Z-score is simply how much that value deviates from our normal control group. So FA and Z-score will be the terms that we need for you to remember as we go further in this presentation. So what is a normal FA or fractional anisotropy? Well, you may recall that I had you compare the movement of water molecules in certain pathways in the brain, similar to what might be electrical current going through a wire that has all types of insulation. So when normal FA is occurring in the brain, it's much like this highway picture, where the cars are moving along, everything's good, people are on cruise control. It's smooth highway driving, no interruptions, everything's really cool. So what happens when that normal traffic pattern is interrupted by an accident? Well, people slow down, and that's what happens in the brain. When you have an axonal injury, the FA gets low. The water molecules start to move more slowly or may even stop. So you have to remember that this is, again, like the electrical pathway. And if there's a short circuit and the insulation gets bad, you're likely to have your lights go off, or your radio stop playing, or your TV go haywire. Well, in the brain, if there's an injury to the axon, it's going to interrupt the water molecule from flowing. It's going to mess up the connection, and well, things are going to slow down, and there's going to be clinical symptoms that go with it.
I'll pause this here. I'm going to skip a little bit ahead. As I said, this is the company that's trying to sell their services, and we don't want to be endorsing anyone and taking any sort of those stances because that would violate BOC policy. About right here is where we're going to be, so we're going to resume the video here.
That is unusually high, or you might have a mixed pattern of high and low. That may be a sign of repair, but that's not proven. It's actually only an hypothesis. So let me explain. So let's talk about how the body might try to repair itself. If you look at the top of this picture, you'll see that there's a bruise to the elbow, and over time, it goes away, may even completely disappear. So let's look now at the lower left-hand corner, and you'll see the mid-portion of a cervical spine, the neck. And you'll notice that there's multiple levels of disc herniations and degenerations where the discs are narrowed, and there's probably been some herniations here. And you'll see that the body has created osteophytes. That's the deposition of bone and calcification to immobilize this region so it won't be active and cause more pain for the body. It's another repair mechanism in the body. Now look here, you see a perfectly normal blood vessel with good flow and some normal branches. What happens over time if that vessel becomes obstructed and narrowed? These branch vessels start to hook up with one another, and before you know it, when the blood vessel is completely blocked, there's an alternate pathway to get circulation to the areas of the body that need blood and oxygen. So here you have three mechanisms of the body trying to repair itself. Well, what about the brain? That's why we're talking about high FA. Can the brain somehow repair itself? I think so, and so do many neuroscientists. We just don't know how this works. But we think that increased FA may represent that effort to repair or accommodate brain damage. In an article by Crowe, Cowie, Peel, and his group from Great Britain, this was published in Neurology in 2013. This is a well-respected journal from the American Academy of Neurology. The conclusion was as follows. Acute, mild, or moderate traumatic brain injury is characterized by increased tissue FA, which represents a clear neurobiological link between cognitive dysfunction and white matter injury after mild to moderate injury. That's an impressive statement, and I think most neuroscientists are working now to try to prove that hypothesis that we had earlier mentioned, that is, the brain repairing itself. And in the next slide, when you hear from Dr. Lipton, he'll mention that as well.
Okay, so we are not going to watch the rest of the video and hear from Dr. Lipton, but the next video I want to give is, once again, another really good detailed piece of information about DTI and the information we can kind of gather from it. This comes from Dr. Andrew Alexander. He is at the University of Wisconsin-Madison, and gives some, once again, some really good, useful information here.
In a diffusion-weighted MRI experiment, images are obtained with different amounts of diffusion weighting. Here is an example showing that the signal in a region of tissue becomes more attenuated as the amount of diffusion weighting is increased. By changing the direction of the diffusion weighting gradients in our pulse sequence, the diffusion-weighted images become sensitive to the anisotropic diffusion effects. Here we have an example of diffusion-weighted measurements in the splenium or posterior aspect of the corpus callosum, which is a major white matter tract oriented in the right-left direction and connects the hemispheres of the brain. When diffusion gradients are applied in the direction parallel to the corpus callosum, as shown in the middle image, the signal is highly attenuated, whereas diffusion gradients that are applied perpendicular to the tract, such as in the right frame, the attenuation will be much less. For diffusion tensor imaging, a minimum of 6 non-collinear diffusion encoding directions are required. The directional dependence of the signals is the basis for measurements of diffusion anisotropy. Here is an example of 12 diffusion-weighted encoding directions. Note each image has slightly different contrast that corresponds to the orientation of the white matter relative to the diffusion encoding. By combining these images to estimate the diffusion tensor at each voxel location, quantitative diffusion tensor imaging maps may be generated that provide descriptive measures of brain tissue microstructure. In addition, the diffusion tensor may be used to estimate the trajectories of the white matter fibers in the brain using tractography. In homogeneous parallel white matter tracks, we can try to relate properties of the diffusion tensor to biologically relevant features of the white matter microstructure. The diffusivities that are perpendicular to the diffusion tensor, as indicated by the green axis, and blue medium axis, which is not shown here, are also called the radial diffusivities and have been shown in animal models to be related to the changes in myelination of the white matter. The diffusivity along the longest axis of the diffusion tensor is the parallel diffusivity and has been, as shown in red, and has been shown to be affected by axonal injury, and again in animal models. By averaging the diffusivities in the three perpendicular directions, we estimate the mean diffusivity, which is inversely related to the density of cellular membranes. The variance of the diffusivities is related to the diffusion anisotropy, which is widely used as a surrogate for white matter integrity. Here we show representative quantitative diffusion tensor imaging maps for a single slice from a DTI experiment. The upper left is the non-diffusion weighted image, or B equals 0 image, which has typical T2 weighted contrast. Below that is the mean diffusivity map. One obvious feature is that the cerebral spinal fluid, or CSF, such as in the ventricles and at the cortical surface, has much higher mean diffusivity because it is a fluid without membranes. White matter and gray matter have similar mean diffusivities to each other and are modulated by the cellular densities. In the upper second column, a map of the fractional anisotropy is shown, which is typically brighter in areas of white matter, though it is highly sensitive to regions with crossing white matter tracks, such as in the anterior prefrontal areas. Below that is a pretty image where the color corresponds to the orientation of the greatest apparent diffusion coefficient, which is assumed to be parallel to the white matter fiber orientations. Here, the RGB color scheme is used to label tract orientations, such that red is right to left, green is anterior posterior, and blue is inferior superior running tracks. The parallel and perpendicular diffusivity maps also show cerebral spinal fluid as bright. However, white matter is bright in the parallel diffusivity map, but dark on the perpendicular diffusivity map. These parallel and perpendicular diffusivity maps are now widely used to try and characterize changes to axons and myelin in the tissue. We can apply these quantitative diffusion tensor imaging maps to compare microstructure between subjects using statistical image analysis methods. Here is an example of a voxel-based group comparison of fractional anisotropy and mean diffusivity measures between two groups, A and B, that indicate brain areas where these microstructural measures are significantly different between the two groups. Another exciting application of diffusion tensor imaging is derived from the orientation information and assumption that the direction of greatest diffusivity is parallel to the white matter fibers in a voxel. Here we zoom in and explore the color mapping at the voxel level. Another way to represent the directional information at each voxel is using ellipsoidal glyphs that represent the diffusion tensors. This also provides both the shape and orientation descriptions of the diffusion tensors. Here is a map that uses vectors to indicate the directions of greatest diffusivity, or the major axis of the diffusion tensor. Using this directional information, estimates of the white matter trajectories may be estimated using the vector field to define the local path direction. In this example, the green dots represent the so-called seed points where the tracks originate. Trajectories are terminated when the anisotropy becomes low, such as in a gray matter or CSF, or when the curvature of the track is too sharp. This is the basis for white matter tractography reconstructions of white matter pathways in the brain. So why is this useful? So let's take an example of the superior longitudinal fasciculus, which also has aspects of the arcuofasciculus, has connections between Wernicke's and Broca's area, as well as projections to the temporal lobe. In a sagittal view of a DTI color map, portions of the superior longitudinal fasciculus may be identified, such as the white matter region labeled in green as indicated by the arrow. Additionally, by using really nifty technologies with white matter tractography algorithms, the three-dimensional trajectories of the superior longitudinal fasciculus may be reconstructed as shown in this example provided by Derek Jones at the University of Cardiff. These white matter reconstructions appear to be quite similar to the most post-mortem dissections, but can be performed on living subjects, which has obvious advantages. So now we may use these tractography methods to reconstruct, visualize, label, and segment specific white matter tracks. In the top image, multiple white matter tracks are reconstructed, including the superior longitudinal fasciculus in red, the uncinate fasciculus in gold, the inferior frontal occipital fasciculus in blue, and the corpus callosum in purple. In the bottom row, tractography was used to segment several major white matter tracks in a single subject. Here are cleaner tractography reconstructions of several of these major tracks on a population-averaged diffusion tensor imaging template. Shown are sagittal and axial projection views of the corpus callosum, which is the main tract for interhemispheric connections, the inferior frontal occipital fasciculus, which connects the medial prefrontal cortex with occipital regions, the cingulum bundles, which connect medial gray matter regions from the anterior cingulate to the posterior cingulate and down to the hippocampus. The fornix, which is a narrow C-shaped midbrain white matter tract that connects the hypothalamus to the hippocampus. And finally, the uncinate fasciculus, which is a fishhook-shaped tract that connects ventral prefrontal areas to medial temporal lobe regions, including the amygdala.
Okay, a lot of information to process, but we're getting into the home stretch. So just kind of tying back to all the information that was kind of given, we are going to be taking DTI, and we really still need to connect it to something else. Just like any advanced imaging, we always need to correlate it clinically, and whether it's a musculoskeletal MRI, we need to correlate it to a physical exam. With concussions, we really need to connect it back to things like either functional MRI or even more specifically things like neuropsychological testing. And neuropsychological testing has been a long-established practice within concussion management. It gives us that brain thermometer of what is that brain doing? What is it doing with information? Where is it putting it? And how quickly is it doing it? And that's very, very important for giving us that idea of overall brain function and when it comes to cognition. So, we're seeing those things of, are we seeing things of loss of short-term memory? Is it long-term memory? Is it manipulation of information? All that kind of fun stuff. But also, good quality, true neuropsychological testing, beyond that what you would get from computerized testing like IMPACT, CogSport, concussion vital signs, where they give us those real objective numbers. They don't get into those domains of emotional components like anxiety, depression, and how neuropsychological testing can illuminate these things, because being someone who's depressed can be a compounding factor, or being anxious can be compounding, because the idea is now your brain's not going to handle that information properly, because now there's this emotional state that is impacting what we do with information, to the point where it can also be confounding as well. So we think about that person who's in that kind of post-concussion state, where we're several months to sometimes a year or more into a recovery, and we would anticipate something being better, but they're not. And then something like neuropsychological testing can go and say, well, okay, one of the things that's preventing them from getting better is profound depression or anxiety. And at that point, now the psychology is impacting the cognition, and not the cognition impacting the psychology. If neuropsychological testing has been completed before DTI, any deficiencies that are found during that testing can really help a physician and the neuroradiologist create regions of interest, or really areas of the brain that we're going to look at very specifically, be it the corpus callosum, the fornix, the hypothalamus, the amygdala, any of those places. Once again, it kind of makes us focus in the same way that we would correlate imaging to a physical exam. We do a Lockman's on somebody. We feel that we don't have an end feel on that Lockman's. We're going to say, hey, I really want you to take a look at that ACL, or positive McMurray's. We're going to look at a meniscus. Okay, same idea. This just kind of helps focus the imaging to those areas. And vice versa, if that data is collected afterward. So the DTI is completed, and then we have neuropsychological testing. A neuropsychologist can then maybe better differentiate between some of the things that they find from let's say cognitive changes, and is that because, okay, I've got a cellular problem, I actually got a functional problem within the brain, or is this a true psychological origin? Kind of going back to what we kind of said earlier, is that you're forgetting things because you have really, really bad anxiety and depression, and that's clouding your cognitive function. Or, like I said, is it because, your corpus callosum isn't working so hot, and that's where we're losing some of that information. So, kind of wrapping up and rounding out our talk, we just want to touch on a few kind of normal neuroanatomy concepts. So, on the left we have a sagittal view of the brain. We have a nice, healthy-looking brain. It's all kind of healthy. It's uniform. The human body has symmetry to it, so the body typically gives us an ability to compare side to side. So everything's consistent throughout. There's no weird changes within the tissue itself. Nice, clean central brain and midbrain. Getting into the hindbrain. Cerebral spinal fluid seems consistent and normal throughout. Shape looks normal. There's no weird voids. Okay, and then same idea here. We come back to our axial view. We got those nice, healthy-looking gray matter and white matter tracts. Our ventricles are symmetrical. They're full of cerebral spinal fluid. They're the right size, so we don't see things like hydrocephaly. Nice and clean and equal on both sides. So that's, like I said, kind of looking through all that stuff. The tissue kind of tells us what it kind of should look like, and then we start seeing some of those inconsistencies. We can start asking some questions. Obviously, getting into the really deep nitty-gritty of some of the abnormal findings, get into true interpretation of MRI, and we do have to remember as athletic trainers that true interpretation is outside of our scope. We don't interpret imaging, but the idea is we should still be able to make heads or tails of something and at least have a basic idea of what we're looking at, and maybe seeing something that jumps out. So obviously as athletic trainers, we're doing our sideline evaluations, and we need to figure out if these people need to go to a hospital urgently or emergently, or can this be a little more delayed referral and maybe go and see a physician in the next couple of days, depending. So obviously the big things that we're going to be worried about are those massive intracranial bleeds, right? So we have the epidural hematoma, where we have the arterial injury around the brain, creating a very distinct marking of edema within the tissue, and it'll be once again very close to the cerebral spinal fluid, but distinctly different. As you can see, it's a kind of a lighter color versus the very, very bright cerebral spinal fluid, as we kind of talked about with some of those imaging, those images that we had, where it's like, free flowing versus not free flowing, early versus old hemorrhage and edema, can once again kind of be differentiated. On the flip side, we have our subdural kind of over here on the right side, and we see this big wad of abnormal looking signal here, but it's uniform throughout. It's separate once again from the cerebral spinal fluid, once again always being a different color because it's a slightly different makeup than the free-flowing water. It's going to be that kind of stagnant venous blood that is collected underneath that dural membrane as opposed to on top of it. Some other types of examples, once again, thinking about the idea of ischemia, we have something like a stroke or cerebrovascular accident. We're going to see some of those ischemic changes within the tissue depending on our sequence that we're using. But once again, we're seeing that kind of appearing here in this patient here in the essentially in the right temporal lobe, and fairly large lesion on there that's creating some of those problems for the patient. Down to, we look at something and we find ourselves something like a tumor. Through various sequences, we can once again manipulate fat versus fatty tissue versus water-based tissues to whether or not we have something that is cytotoxic edema or ischemia in the tissues. So once again, we're getting these very big bands of abnormal tissue, and like as we talked about, kind of looking at, are we healthy and consistent? This stuff looks the same here on this side too. That does not look like native tissue. Same thing here, where you have these vastly different, weird, abnormal looking stuff that doesn't appear anywhere else. They're very marcated, and even get into some of the like that kind of native lesion there, into some of the spreading edema that the thing is creating as well into its surrounding tissue. So kind of just summarizing, in a little bit longer presentation, and a lot of information that's been thrown at you as we've gone through this. Remembering that this advanced imaging needs to be completed based on their presentation. Do we have an acute problem where we really need to rule out life threats? And that's where we're going to go more CT. We have some more chronic presentations and changes. This is where MRIs can be very, very beneficial for us. If we're looking for more functional imaging, where we're looking at what parts of the brain are working, that's where the functional MRI is tremendously helpful. Or if we want to look at cellular metabolism, that's where the PET scan is going to be ideal for us. Brain MRIs, especially with the addition of DTI, provide quantitative data on the integrity of the neural microstructure and its overall function, and that's important because it helps guide what we're going to do with our patients. Abnormalities that we find on structural MRI, like tumors and lesions, and really structural problems, if those things come up, those are going to need referrals to neurology or neurosurgery, because things like MS might need to be controlled through medications. Things like tumors and blood collections and bleeds might need to go through neurosurgery for evacuation or dissection, depending on what might be going on, or even into things like reperfusion. So, we send someone and they've got something like a blockage from a stroke. Maybe reperfusion from the standpoint of we're going to need to use medication to break down clots, or they might need surgery to cauterize vessels or pull clots out that aren't going to get broken down by medications because perhaps they're too old or where they're at isn't exactly desirable for drug-based therapies. If we're finding abnormalities in regions of interest during DTI, we have to obviously correlate these things with really quality findings, things and testing that we would get from, say, neuropsychology, so we can really kind of go and see, does this need cognitive therapy, or is this going to benefit from cognitive therapy, or does general speech therapy, is it something like psychotherapy where it's going to have to be working through coping mechanisms and mood control and different things like that from that nature, like, is that going to be the best treatment for this patient, or are we going to need to is the patient potentially going to benefit from something like psychopharmacology, like antidepressants or anti-anxieties or seizure medications, or what have you? Can we titrate our drug treatment to what is going to be most effective for this person? And overall, as athletic trainers, we need to have we can look at images and have a careful, systematic review of sequences to kind of tell us, do we see something that's abnormal? Do we see something that stands out a little bit? And then moving up to, say, like our physicians and our neuroradiologists, that they can compare things to these atlases that have been compiled and really be able to give good quality reports that, once again, guides us and our physicians to make the best decisions for our patients. This is a list of references that I have for the different sources that we have here. About 13 of them. Certainly, they're all good quality ones to consider looking at in a little more detail if we were so inclined. And that brings us to the end of our course. I do thank you for your time that you've put in advancing your learning in your clinical practice. If you do want to take this course for continuing education, I would direct you towards our website, pssconed.weebly.com, and you can either go straight to the home-study- offerings HTML page, or if you go to our website, you can go click on that in our navigation bar. And there's a quiz that you would be able to take if you are already a registered member with Premier Support Services and have a membership. You can use your normal class marker login data. If you're taking this course kind of a la carte, there's a button you can click on that will take you to the checkout, so you can purchase the quiz and take it. And if you are, once again, taking this for continuing education, we would also ask that you complete the BOC participant assessment form. As I said, this is a BOC requirement that helps us measure our outcomes and ensure that we're providing the best instruction for all of you. Thank you again for your time, and I hope you come back to us soon. Thank you.